Hi, my name is Julianna Davis, and this is my presentation of my working theory of counseling. I would like to begin by telling you a little bit about myself. I am currently not a licensed counselor, so I do not have a lot of the experience that some of my colleagues will have as far as implementing these theoretical approaches to counseling. Right now, I work as a qualified developmental disabilities professional. So a lot of the counseling that I do with the residents that live in the group homes that the company I work for owns is, I guess, what you would consider lay counseling. So I do spend a lot of time with them. I help them make good decisions. I help them make changes in their life, and I help them deal with problems that they're going through. But I don't present my working theory of counseling to be a clinical approach because I can't claim to give clinical counseling at this moment. So I would like to begin explaining my theory with a Bible verse. So Proverbs 23:18 says, "For surely there is a hereafter, and your hope will not be cut off." This kind of sums up my personal belief about my working theory of counseling. I believe that change is possible through hope, work, forgiveness, and love. I believe that the Bible gives us the one and only absolute foundation on which to base our wants and our needs for change. However, I understand that in a lot of clinical settings, and even in my setting with it not being so much clinical, but I'm not allowed to share my faith. I'm not allowed to use biblical or Christian counseling methods. So, that's going to be a part of how I explain why I've chosen the theories that I have chosen to base my working model off of. My personal working theory of counseling is a blend of cognitive behavioral therapy with rational emotive behavior therapy and forgiveness therapy. I combine these three to base my working model off of because I believe that cognitive behavioral therapy, rational emotive behavior therapy, and forgiveness therapy all help clients realize their faulty beliefs and their faulty cognitions that are the foundations for their interactions with the rest of the world. Faulty or irrational beliefs cause faulty decision-making processes and faulty decisions, which in turn harm the client or their well-being or their satisfaction with life even more. These faulty or irrational beliefs can impact every decision that someone makes, whether it be big or little, from what someone eats all the way up to dramatic things like abusing drugs or, continuing a cycle of abuse or something like that. How do I combine these? I combine cognitive behavioral therapy, rational emotive behavior therapy, and forgiveness therapy by utilizing techniques and strategies from each of these models in order to help clients quickly and efficiently. A lot of times I start by letting the person I'm helping explain their current dilemma or the current situation that they need help with. I draw in pertinent information from the past. I set goals for future therapy sessions and for their life and things that they're working towards. And then I help them heal damaged relationships. And these relationships, I truly believe, can impact a lot of different aspects of their life. And I do believe that people can have a damaged relationship with their self. And so, by using these forms of therapy that concentrate a lot on thoughts, actions, and choices, then, we're able to lay a positive foundation for real change and immediate change and quick change in someone's life and help them overcome obstacles, even in very brief sessions. I also am a big proponent of forgiveness therapy because I believe that not only is forgiveness therapy a very biblically applicable therapy, the Bible says over and over again, forgive thy neighbor, forgive 70 times 7. It's a very biblically sound therapy model, but also forgiveness therapy helps people heal without permission from anyone else. And that's something that, I really like to encourage the people that I work with now is, taking responsibility for their own choices, taking action, and, really having the confidence to make their own decisions. And I think forgiveness therapy lays a really good foundation for that, because if you can choose to forgive someone who has wronged you, then, it makes other decisions seem not as difficult, because that's one of the hardest things that we can ever do. All right, moving on now to some of the benefits of the theories that I have blended for my working model. The benefits of blending CBT, REBT, and FT are that anxiety and depression and other mood disorders are the most diagnosed mental illnesses in the United States. So approximately 10% of the population suffers from a mood disorder, and almost 18% of the population suffers from an anxiety disorder. These are the most common mental disorders that I encounter in my line of work right now. So obviously I work with a population of people who are intellectually disabled, and the majority of our residents also have a dual diagnosis of some sort of mental illness, and it's usually the combination of a mood disorder and anxiety. Dreisen and Holland and Taylor, Lindsay, and Hastings and Hatton found that these were the most common disorders, and they were most effectively treated by these types of cognitive behavioral therapies. CBT and REBT and FT are all empirically supported treatments for these disorders. Sutton and Friedman all found that these therapy models can accommodate a varied population and are applicable over many walks of life. So Hayes and Iwamasa found that these therapy models are applicable to children. They're applicable to people with intellectual disabilities, like the people that I work with. And they're generally applicable to multicultural aspects and different multicultural groups. There are some sensitivity issues. Seligman and Reichenberg found that even though these cognitive and behavioral therapies are generally applicable to other people of different ethnicities and minorities and different demographics, that over 90% of the counselors that practiced these therapy models were white adult counselors. So it is important that we take a careful approach when dealing with people from different backgrounds from us, because, or from myself, I should say, because it could be possible that I could have some bias. It could be possible that I could be ignorant to some of the cultural aspects. But generally speaking, these are applicable to many different walks of life. They're also applicable to group counseling, which is something that I implement a lot. I don't have a lot of time. There are no resources at all, really, for the population that I deal with to receive counseling services. So like I said, when I do my, I guess you could call it lay counseling services, I do implement a lot of group sessions. Another caution with utilizing these three therapies that I've talked about is that I feel like there's a possibility of prioritizing the self over the family unit or over someone's relationship with God, because these therapy models are all secular. They're all individualistic, and so I feel that it could be dangerous, or it could be damaging when you're working with someone who maybe comes from a family unit background, maybe an Eastern culture or a South American culture where the family unit is valued over the individual, I feel that it could possibly damage the family relationship if you didn't pay enough attention to that aspect of their background. I also feel that we know that REBT has the possibility of minimizing or even invalidating victims' feelings, or I should say survivors' feelings, regarding trauma, especially sexual abuse, childhood sexual abuse, and things like that. David, Sinsatogi, Eva, and McAvey found these aspects of the possibility of cultural insensitivity that I just told you about. Cognitive behavioral therapy is the most empirically supported treatment, even second to medicine, for mood disorders such as depression. This was found by Esbenson, Hart, and Hartley. I'd like to give you an example of how I used some aspects of cognitive behavioral therapy the other day to assist one of our residents with making a decision. So I would like to tell you about, I'm going to call him Joe. I had an example with Joe the other day. So obviously I work for a company that has several group homes all across the state. And I deal with a lot of depression, and I deal with a lot of people not feeling safe, not feeling valued, not feeling loved. And I also deal with a lot of people lacking the ability to make decisions on their own and feel confident in those decisions. And obviously part of this comes from the fact that they are intellectually disabled. But when they live in a group home, the goal is to help foster independence and help them be able to do these things on their own that someone without an intellectual disability would take for granted. So the other day, Joe came to me, and he had been working this job at a restaurant in the kitchen for over a year. And he came to me the other day and he said, "I want to quit my job. I'm done working." And I said, "Okay, Joe, what's going on? Why don't you tell me, sit down and tell me what's going on with you?" And he said, I really want to quit my job. I'm done. I don't want to work anymore. I really don't want to go back. So I helped Joe think about how he was feeling and think about the decision that he was about to make. And we actually got out a piece of paper and we made a pros and cons list, and we decided together on what would be best for him. So I had him list out the reasons that he wanted to quit his job, and I had him list out the reasons of why he might want to keep his job. Well, the reasons to quit the job outweighed the decisions to keep the job. So he did decide to quit his job. And he said he just wanted to quit right then. He wanted me to take him down to his job right then. He was just going to quit. And I asked him, how this might affect him in the future. And, he was able to say, "Well, I'm worried that my dad will think I'm a bad person because I want to quit my job." And I said, "Can you explain to me what do you mean? Why do you think your dad would think you're a bad person?" And he said, "Well, my dad thinks everybody should have a job. My dad thinks I should work. And I'm afraid that he'll think I'm a bad person." And I said, "Do you think that he would think you are a bad person, or do you think that he might disagree with the decision that you're making to quit your job?" And I helped him understand, after a couple of days worth of conversation actually, that his dad probably wouldn't think he was a bad person for quitting his job, but that he probably wouldn't agree with the decision to quit his job. But I also helped Joe understand that his decisions are his own. So we continued to discuss the implications of quitting his job and what this might mean for future work endeavors. And I explained to him that most people are expected to give a 2 weeks notice before they quit a job. And he was like, "I just want to quit right now. I don't want to go back." But through using another pros and cons list, and through, we actually did some consequence, kind of like role play, where I asked him, like, what would happen if you just quit your job right now and then you wanted to go tomorrow and apply for another job and Cracker Barrel gave you a bad reference. And, you know, he was able to discuss with me and determine that it would be better for him in the future if he worked out his 2-week notice so that he could use Cracker Barrel, his previous place of employment, as a good reference for the future. So we wrote a letter together. He signed it. He went down to Cracker Barrel and he turned in his 2-week notice. And he, you know, he was able to use the decision-making models, the pros and cons list, the what-ifs, the role-playing, and things like that to make a better decision than he was going to have on impulse, like when he first came to me wanting to quit his job. I honestly believe that he was also able to understand that there wasn't the extreme polarity there of his dad thinking that he was going to be a bad person because he quit his job. He actually did speak to his dad, and his dad really wasn't even as disappointed that he quit his job as he thought he would be. But he did understand that it was not a logical belief that quitting a job makes someone a bad person. So I felt like I was really able to use some things that I've learned over the last few years. Even though I'm not a licensed counselor, I felt like I was able to use some really detailed and really specific techniques to help someone make a good decision. And in the population that I deal with, quitting a job is a huge decision. And so I was really proud of him that he was able to go about it the right way and make the decision on his own with a little logical influence for myself. Alright, so now I would like to address the issue of influences on current distress of my working model of theory, or working model of counseling. So I believe a little bit differently than the majority of cognitive behavioral therapists or rational emotive behavior therapists. I believe that background plays a lot more of a role than we give it credit for in these therapy models. I don't believe that faulty cognitions develop in a vacuum. I believe that they have developed over usually a long period of time due to environmental or personal circumstances, whether it be a family environment or some past trauma, or maybe even a chemical imbalance in the brain resulting in some sort of mental illness. But I do believe that something important in the past has happened for people to feel the way they feel. I do believe that it's important to take a full intake and garner as much information about the client as possible. Moran and Moore also found this to be applicable in dealing with special populations. And I've seen this play out to benefit the clients in the last couple of jobs that I've had. So right now, as the Qualified Developmental Disabilities Professional, we spend a lot of time, tracing down family histories, medical histories, substance abuse histories, finding out, medical histories of siblings and parents and how the pregnancy was when the person with the intellectual disability was in the womb. And, we spend a lot of time chasing down the backgrounds of the people that we serve because, like I said, I don't think people are who they are if not for their backgrounds. So, I also believe, I spent the last 5 years before I took this full-time job as a qualified developmental disabilities professional as the assistant to a clinical psychologist, and I administered psychometric tests for people who were applying for disability or vocational rehab in our state. And one of the things that the psychologist that I worked for taught me was that you can garner a lot about the person that you're dealing with from a full, very detailed historical intake assessment. So I think this is important because I don't think people can understand where they are unless they really understand where they've come from. And I also think it's very important for us as counselors to make sure that history is not repeating itself. So I'd like to use the example of someone who comes in for counseling and they really downplay their use of alcohol or their abuse of alcohol or their amount of drinking. And you know, if the counselor were not to do an intake assessment and ask about family history and find out that this client, a 40-year-old male who downplays his use of alcohol, had 2 alcoholic parents, then we as counselors really might overlook his potential to become an alcoholic, or that he may be an alcoholic and be in denial. And this is where I think that background really plays more of a role than traditional cognitive behavioral or rational emotive behavioral therapists give it credit for. I like to use a lot of assessments. Like I said, I've had 5 years of psychometric testing experience, so I'm a big assessment person. I like to use tools such as the ADD, the Assessment for Dual Diagnosis, the BDI, the Beck Depression Inventory, and the BAI, the Burns Anxiety Inventory. Like I said, the majority of people that I work with suffer from depression and or anxiety, other than that, it's usually some sort of personality disorder, or, you know, obviously we have a few people with schizoaffective or schizophrenia. But anyway, these assessments allow me to be able to get more information about the person and get a baseline on the person. And then throughout the year or throughout the counseling session, or like right now in my current job, everything's done on a yearly basis. So throughout the year, I like to administer these assessments again and compare them to the baseline and see if we've had any improvement. If, you know, we do a lot of monitoring. We monitor every aspect of the person's life, and we report this back to the psychiatrist for medication management and things like that. So I really believe in assessments. I really believe that they also help foster a sense of an open therapeutic alliance, you know, because you can sit with the person while they are taking the assessment, and they can see the results, and they can get their number, or they can get their, you know, like the Beck Depression Inventory has 4 different categories of how depressed someone is, and you can share this with the client, and it's an honest and open means of communication about their current status. And so I like to use that. So I do believe that background plays a very important role in people's current distress. All right, moving on to emotions. Emotions are our ways of expression to the world around us. Emotions regarding events that have happened in the past can carry forward into the present. For example, I work right now with a survivor of childhood abuse who was abused in the small town that we all still live in, and she has quite a few panic attacks when she's in a certain area of town, you know, passing through, going to Walmart or something like that, from memories of where the abuse happened. And she has panic attacks relating to the fear that she's going to encounter her abuser. Also, current emotional states play a huge role in the therapy process. I don't believe that a lot of work can be done or a lot of change can be made when someone is in an extreme state of emotion, such as anger or resentment. It's my philosophy that if a client presents with an extreme state of emotion at the time, I listen, I validate it, I give name to it, I help them express it, and then I also try to help them bring it back down or bring it back up if it's, you know, a depressed state or something like that. Kind of back to a baseline so that we can begin effective communication. For example, one of the residents I work with now has extreme mood swings, and she lashes out in anger and has completely irrational and self-defeating behavior when she's in these extreme moods. When she's so angry, she starts a vicious cycle of maladaptive behaviors, which result in consequences, which result in more anger. I've noticed that if I can reach out to her and if I can assist her in calming down through activities that she enjoys, such as deep breathing, coloring. She has a garden out behind her house where she can calm down sometimes, looking at the vegetables and picking flowers and things like that. If I can help her with that, then I'm able to speak with her in a rational way, and we're able to achieve something. But when she's in that full-blown anger, there is no consoling, there's no work that can be done. It only escalates, it only gets worse for everybody, including the resident, myself, and the staff as well. So I'd like to give you an example. One day, she asked the staff to make her a cheese sandwich. Well, our staff was not actually allowed to fix her that cheese sandwich at the time because she was already over her calorie restriction that was ordered by her doctor. So, you know, as soon as she heard that no, we can't fix it for you right now, you know, you're already over your calories, she went into a full-blown rage, threatened to kill all of the staff and burn the house down. And so I was able to go over there. I got out her coloring books, we colored for a minute, and then we were able to talk. And I asked her, I said, you know, why were you so upset? What is it about the cheese sandwich that got you so upset? And she said, well, I'm hungry. I feel like they're starving me and I really want a cheese sandwich. And I was able to, since she was in a much calmer state, I was able to say, well, you're welcome to go into your kitchen and fix yourself the cheese sandwich. But, you know, when you reacted so extremely like that, you know, the staff didn't have a chance to explain to you that they couldn't fix the sandwich because it went against doctor's orders, but that you can fix it because you can make your own decisions. So when she understood that she was able to make her own sandwich and she was still able to eat that cheese sandwich, that we weren't starving her, that she just simply didn't get all the details of the story, she made herself a sandwich and she was happy. But it wasn't until she calmed down out of that extreme state of rage that I was able to even reach her and find a solution. Okay, thoughts. I believe that thoughts are like the jackpot of cognitive behavioral therapy, rational emotive behavior therapy, and even forgiveness therapy. All of these therapy systems focus on thoughts, which are the foundation of every other aspect of life. Relationships, social interactions, decision making, etc. These are all influenced heavily by our thoughts, almost solely by our thoughts, because even, you know, we know that no matter what's going on around us, we as sound, mentally stable human beings and, you know, healthy human beings, we have the ability to control our thoughts and our behavior. This is why I think it's so important to focus on finding these irrational thoughts, challenging them, challenging the emotions that come with a certain thought. I mean, a lot of times, you know, we can work ourselves into an emotional state that is non-productive just by thinking about something. So, it's, you know, cognitive behavioral therapy focuses on finding the irrational thoughts, and rational emotive behavior therapy focuses on finding the extreme emotions or the extreme black or white consequences that go with an action or that go with a feeling. And, you know, forgiveness therapy focuses on choosing, which is a thought, to release oneself from bondage with another person who has hurt them. So without rational, constructive thoughts, I don't believe that anybody can act or function in a way that is the most beneficial or purposeful or constructive to their life. For example, if a man believes that his boss is out to get him at work and he wants to fire him, you know, that man may in turn act in a way that causes natural consequences, which in turn reinforce this irrational belief that he had that his boss was out to get him. So, for instance, you know, he may treat his boss with contempt. He may be nervous and not do his best at his job. He And then if he's disciplined or he's reprimanded or something like that, then he will internalize that, and that will be like a reinforcement to him. Oh yeah, my boss was out to get me. I was right to begin with, so what does it matter? And this is an example of what Seligman and Reichenberg call a schema. A schema is kind of like a scenario that we already have played out in our head of how things are going to go. And it's really important in these therapies that I like to utilize that we challenge these schemas. Okay, actions. Actions are the byproducts of thoughts. There are very few actions in this world that are involuntary. Things such as blinking and swallowing, obviously they are involuntary, but not many actions that actually have consequences or implications for life are involuntary. They all involve a decision. Each person has a motivation for doing what they do. These motivations come from thoughts which have usually evolved over a period of time and influence, like I said, decisions from small to big. I believe that actions are also influenced by things like personality and circumstances, but our thoughts largely control our actions. Therefore, if the aforementioned thoughts can be logical, then the decision that follows will obviously be logical as well. A huge part of my working theory of counseling involves analyzing actions and asking questions like, how's that working for you? What results have you gotten from acting that way? What would happen if you acted this way instead? So utilizing some techniques of cognitive behavioral therapy like pros and cons charts, journaling, lists, consequences, things like that, can be very helpful in helping clients analyze their behavior from an objective standpoint and help them make a decision based on facts and evidence rather than just relying on impulse or even habit to make a decision. I feel that rational emotive behavior therapy can be useful in analyzing actions because if one can understand and analyze where these extreme emotions and actions are coming from and that they're not logical, then they can begin to act in a way that's more appropriate, and oftentimes just not doing what they're used to doing in a situation results in positive reinforcement of a better emotional state. And in turn, they are not put into the same extreme emotional distress that they're used to because, like everyone says, doing the same thing over and over and over again in the same situation causes the same outcome, and that's the definition of foolishness. So if you simply change your action, then you may get a completely different reaction, which works out a lot better for you. Family. Family plays a large role in my working theory because I think that every client has been heavily influenced by their family at some point in their life. It may be, like a lot of the clients that I serve now, they don't have contact with their family, they don't have a relationship with their mother, but they may be diagnosed with fetal alcohol syndrome. So obviously their family played some sort of very important role in their life and in determining the course of the rest of their life, even if they don't have a current communicative relationship with the family. I also have seen a lot of parents who are very codependent with their grown adult drug addicted children. I have a coworker actually who is going through that right now. But family has an inevitable influence on each of our clients to a certain degree. There are very few people who don't have any contact with their family whatsoever or don't have anybody that they consider a family, even if it's not a biological family. Everybody usually has somebody that they consider family, and so the family history, the current family situation, all of that can play a huge role in what the person is going through at the time. I think it's ideal for the family to be involved in therapy if possible. Maybe not in the beginning, but maybe in the end, or as a couple of sessions of group family therapy or something like that, because we want the family to be on the same page. We want family to be supportive. And you also want to take the time to identify any pathology that may be in the family that you didn't know about beforehand. On the other end of the spectrum, sometimes family can be the best part of therapy for your client. For instance, you can have a client who has a wonderful family at home, a wonderful support system, great encouragement, and they're really struggling with some depression and maybe even suicidal ideation, and it's that family's intervention that really is like the catalyst for them to get help and get better. So sometimes family can be detrimental to therapy, but also sometimes family can be the best thing for therapy. We also know that family can influence our clients genetically. Like I said beforehand about the adult male with 2 alcoholic parents who doesn't recognize the danger in abusing alcohol in his own life. So without that family knowledge of the history of alcohol, alcohol abuse, it would be very easy to overlook the possible alcoholism in the client. Okay, cultural aspects. This is one reason I'm such a proponent of these thought and emotion-based therapies. There's less to worry about offending people's cultural sensitivities as opposed to other therapy models such as traditional psychoanalysis. Traditional psychoanalysis was pretty chauvinistic, and even now with some of the newer therapies like feminist therapy, I find that it can be offensive to some cultures that still expect and desire for there to be a difference in gender roles. So for instance, a couple of examples would be a young Asian male who resents his role as a caregiver to his grandparents with whom he shares a home. If he were to fully embrace the individualistic nature of these therapies, he could risk being ostracized or shamed or even cut off from his family, because in some Eastern cultures, it is expected of the younger generation to care for the older generation, but here in America, we don't see that as much. So if you were dealing with an Asian American family, you would have to be especially culturally sensitive to that cultural background aspect. The other example that I was trying to say was, for instance, like some South American cultures or even Southern American cultures where the woman is still expected and it's socially acceptable and it's socially expected for the woman to be in sort of a subordinate role with her husband. Feminist therapy could even be offensive to someone from, say a small Alabama Southern town from a Southern Baptist church, where the woman is expected to be subordinate to her husband and follow him as the leader in the home. So, there aren't a lot of risks when applying these types of therapies to other cultures, but there are some, and they are important. And so it's very important. Again, that's why I think the background information is so important, because if you know where someone comes from, then you know more about their cultural identity and their family identity, and you can avoid offending or having bias when dealing with different cultures. However, in general, Voss-Harrell found that CBT and REBT have both been found to be applicable and minimally offensive in a multicultural environment. Okay, moving on to the next category of how is meaningful change achieved. Meaningful change is observed in the client through the correction of faulty cognitions, less maladaptive behaviors, a reduction in physiological symptoms, and an overall better quality of life. I like to base my idea of meaningful change off of Maslow's hierarchy of needs. So, for instance, a client comes in. They're not very happy in their life. They're merely surviving. They're eating food. They live in a house. They have shelter. They have water. They have clothing. Their needs are met, but they're not thriving. Meaningful change would be helping this person discover why they're not happy, discover why they're not thriving, solve the problems, change the faulty cognitions, replace the maladaptive behaviors so that they could move up in the hierarchy and achieve things such as abstract and emotional needs being met, meaningful relationships, and hopefully eventually realizing their full potential, which Maslow calls self-actualization. Many people we encounter are merely surviving, living paycheck to paycheck, no meaningful activities, no meaningful relationships in their lives. To be able to assist them in reaching higher goals such as emotional satisfaction, self-actualization, spiritual fulfillment, these are ways that we can measure meaningful change. I believe that this happens by measuring and monitoring practical constructs. I'm really big on empirical evidence. So, for example, if the person is feeling less depressed than they were when they started, then that's meaningful change. Is the person thinking more logically than they were before? Then that's meaningful change. Are they able to interact more rationally in life with other people than before? Then that's meaningful change. And has this person developed the tools that they can use on their own as opposed to in a controlled environment like a therapist's office or something? Can they use these tools in the real world to help themselves in real life settings? If so, then that is meaningful change. I'll give you an example of something that I witnessed the other day at my job, and this is going to seem really insignificant to a lot of people, but in my line of work it's huge. So, meaningful change. We assist individuals with intellectual disabilities in group homes, and the goal is for them to become more independent. So we have a 48-year-old female who lives in a home by herself, and she's severely intellectually disabled. The other day, at the age of 48, she fixed herself her own cup of water from the sink and drank it by herself for the first time ever in her entire life. This happened after 6 months of intense independent living skills training. So the staff would hold her hands and guide her to the sink and use her hand to turn the water on, use her other hand to hold the cup, and they physically assisted her with fixing a cup of water for 6 months before she could do it on her own. We used a lot of positive reinforcement. You can do it, you're doing so well, this is how you're doing it great, keep going. And also by just practicing. She practiced fixing that cup of water every day, multiple times a day for 6 months. And then one day, she just got up out of her chair and went and fixed her cup of water by herself. And, we were rejoicing because, for someone who had lived 48 years without the ability to fix their own glass of water, this was a huge and meaningful change. And it was very satisfying not only to her, but to those of us who had assisted her with that as well. Another way that I feel meaningful change is achieved is through the working of the forgiveness model of therapy. I believe that in this fallen world, we've all been wronged and we have all done wrong. The forgiveness model proposes that forgiveness is a repeated, intentional, daily choice that allows the survivor of some sort of wrongdoing to forgive the other person without any permission from anyone else. It's an independent, rational decision not to be connected to someone who has done you wrong. Sutton found that this model is often used with sexual assault survivors or survivors of other crimes, but Reed and Enright found that it could even be applied in closing phases of therapy, such as dealing with substance abuse or things like that. The 12-step model is really big on forgiveness and also asking to be forgiven. So the forgiveness therapy model can be applicable on its own, but also as a tool that can be used in the closing phases of subcognitive behavioral or rational emotive behavior therapy sessions, because I really feel like it kind of ends the therapy sessions on a positive, healing note. I also feel that this therapy model gives us the best chance of any of them to incorporate our Christian worldview into therapy whenever we're allowed to do so in the workplace. After all, God's plan in Jesus was the ultimate example of the forgiveness model. And the forgiveness model and the benefits to spirituality were studied in the Friedman study. Moving on to the key treatment strategies that I like to use. First of all, I believe that the therapeutic alliance is very important. So, I didn't incorporate much of person-centered therapy into my working theory, but this would be the one place where I really should have pulled more from that, I suppose, because I do believe that it's very important to show unconditional positive regard, build self-esteem with the client, and speak gently and kindly, even if you're confronting a very tough situation with your clients. The ABCDE model helps identify irrational beliefs and what causes one to think this way and why it's faulty. So obviously, the ABCDE model of REBT it's a very systematic way of identifying what happens to make someone feel this way and why it doesn't have to be that way and so forth. I also like to use a lot of role playing. So I like to help people practice when they're going to have a tough conversation or deal with a dilemma. So just like I used the example of Joe quitting his job, I actually pretended to be his boss. And, I said, "You can't quit your job. That's not up to you." And I explored different possibilities of what his boss might say, which I knew he wouldn't say that, but I'm just saying, we were practicing different possibilities so that he would be confident enough to go into his workplace on his own and quit his job the way he wanted to. Another thing that I use a lot in my current job is assertiveness and communication skills training. So obviously, working with the intellectual disabled community, social skills, communication skills, and assertiveness are lacking a lot of times. I mean, we know that it's very common for people with intellectual disabilities to be taken advantage of. So I do a lot of work helping people communicate their needs, helping people communicate their wants and their expectations from other people. Another thing I like to use, planning meaningful and fun activities. And I kind of base this off the motto or the saying, fake it until you make it. So, that may sound kind of superficial, but what I mean is that a lot of times I have people who come to me and they're scared to do something, or they're intimidated to do something, or they're too nervous. And I say, just try it. Just try it. Go in with a good attitude. Try it one time. And if you hate it, you never have to go back again. But if you don't hate it, then you've conquered something that you were a little bit scared of. So most of the time in my line of work, when someone's nervous about doing something and I say, just put your smile on and try it anyway, they usually end up enjoying it anyway. I also use the technique of challenging automatic thoughts. I've dealt with family members before who had a really negative, pessimistic, paranoid, automatic train of thought. And so challenging that and saying, why would this person be trying to do you in? Why would this person be after this or after that? Challenging it and trying to get them to actually articulate a reason. Sometimes they get caught in their own, they get caught by how silly it sounds after all, because, they can't explain it. They don't have a logical reason. I like to use homework. We do a lot of journaling activities, asking clients to try new things, asking them to come up with ideas of what they want to work on, especially right now in my line of work. We do daily trainings, and so I ask the clients to do a lot of homework every day based on goals that they want to achieve in the future. And finally, one of my favorite techniques is decatastrophizing, and I actually have to use this strategy with my husband a lot. And I have to say, if you try this, what is the absolute worst that could happen? So decatastrophizing, making people actually articulate what could be the worst possible outcome, and then realizing that it's not really a catastrophe. That's a very useful tool in assisting people to kind of get unstuck. Alright, moving on to incorporating the Christian worldview. My working theory of counseling combines theories and techniques that allow for biblical knowledge to shine through. For example, my theory is one of hope and change, a key theme in the Bible. This includes the knowledge that people have the capacity for good, but we often have to work really hard at being good, even after we're saved. The Bible says, "For we have all sinned and fallen short of the glory of God." But the Bible also says that God has given us the ability to be of sound mind. Therefore, that leads me to believe that these cognitive and behavioral strategies are biblically sound when applied in the right context, because it is Christ-like to analyze thoughts and make decisions based not on instinct, not on that instinctual fallen nature, but on biblical guidance. I especially love the forgiveness model when allowed to use it in a setting that allows me to share my faith, because the forgiveness model is not only a proven, empirically supported method to promote healing, but it's also a biblical commandment to forgive those who have done us wrong time and time again, and to turn the other cheek and let God sort it all out later. I can easily see where the downfall of cognitive behavioral therapy and rational emotive behavior therapy would be the emphasis on the self. While it's biblical for us to take care of ourselves, I feel that these therapies could possibly promote the self as the highest authority or the ultimate authority over our thoughts and actions, and kind of ignore the spiritual aspect, or for us as Christians, ignore the aspect of the Holy Spirit. Even Christians, I think, have to pray and ask daily for God to take the sins out of our heart, challenge the thoughts that come into our mind. I mean, we all have the tendency to be jealous, or to be lustful, or to be envious, or to be gluttonous, or something like that. And we have to ask God to challenge those thoughts, or ask the Holy Spirit to help us challenge those thoughts. So I do think that they can be biblically sound, but I could see where in a secular setting they would promote the self and what I want and what I want to do and what's right for me and what feels good and what makes me feel good is the highest authority. And we simply know as Christians that that's not true. If a counselor was allowed to use their Bible in a clinical setting, I feel like these theories could easily be applied using a Christian approach and comparing thoughts and actions to God's Word. I believe that spiritual well-being plays a role in a person's overall functionality. So to be able to utilize these empirically supported, proven treatment methods in a spiritual setting, that would be ideal. Unfortunately, that's not the case for most of us. Moving on to scientific research and how it influences the theories that I have incorporated into my working theory. Research says that cognitive behavioral therapy is the most researched method for mood disorders. David et al. Found that CBT and REBT and a couple of the other cognitive therapies were there was more research for those supporting the treatment of mood disorders and anxiety disorders than any other therapy models that have been discovered. Also, Dreisen and Holland, Esbenson and Hartley, and Fitzpatrick all found that the efficacy of cognitive behavioral therapy and rational emotive behavior therapy are the most empirically supportive and the most effective. Like I said, even more effective than medicine. These theories rely on scientifically formulated assessments and tools to start and continue treatment, such as standardized inventories and scales. So Moran and Moore found that it was important to analyze patients' levels of depression, especially when dealing with any sort of dual diagnosis, while treatment ensued with cognitive behavioral therapy. Empirical research keeps developing for the application of CBT and REBT in new settings, such as in the medical field with patients with incurable diseases, multicultural populations, and also research has found that adaptations can be made for children and other special populations. The value of empirical research is huge in my working model. I also think that, having that empirically sound and empirically proven background of research or body of research is something that I can share with my clients, and I can say, look, we're going to tackle this together as a team. I have some methods that are scientifically proven to help you with what you're going through right now, and we're going to work on this together. And I know that you can get the results you want, because if you put the work into it, it will work. So I feel like it's a way, even using that empirical research to foster a better therapeutic alliance, because it kind of fosters hope and it instills courage in clients who may be nervous about entering some sort of treatment. Also, forgiveness therapy has been proven, and it was found in the Reed and Enright study, to help clients not only with PTSD, but also with mood disorders such as depression and other mental illnesses such as anxiety. So all of the models that I have blended together for my preference of treatment are empirically supported, and they do have evidence that supports the treatment of the things that I deal with most commonly. Multicultural considerations. So Hayes and Iwamasa, Seligman and Reichenberg, and Boss-Harrell found that all of the studies, or all of the theories that I have spoken about, are applicable to a wide variety of ethnic and multicultural backgrounds. I believe that these therapy models are applicable evenly to men and to women. I believe that these are applicable to children, to people with special needs, and especially to groups. They're applicable to the medically needy, to the physically healthy. They're applicable to people with mental illnesses, and for people who just simply need a boost in life. I don't feel that socioeconomic status plays much of a role in the effectiveness of therapy, but I think it plays a huge role in the availability of therapy. So mental health centers and counselors who do some benevolence counseling and things like that, they often have to improvise and adapt these methods to brief, time-limited, very focused sessions, often incorporating group counseling sessions or maybe some individual sessions, maybe 1 to 3 sessions with a client or something like that. So fortunately, these methods have empirical support for the improvement in functioning and quality of life in group sessions, or for people who are entering individual counseling in as little as 1 session. So I hope that I have sufficiently addressed all of the categories of this assignment, and I hope that I've been able to articulate my working theory of counseling. Thank you.